So when we treat hypertension, we always start with lifestyle modification. So lifestyle modification is an integral part of any hypertensive therapy. So, weight reduction, uh, dietary manipulation, exercise, and reduction in alcohol consumption. So those are important treatment in any stage of hypertension. And when we treat hypertension, we look at the overall patient health, and that's what we want. We want to improve the patient's overall health. And in particularly, we want to reduce the risk of future adverse cardiovascular disease. Because as you can recall, hypertension is one of the risk factors for cardiovascular disease. So, all right. So, as we mentioned before, it's a combination of therapy, the non-pharmacological and the pharmacological. So it's not one or the other. It's a combination. And if it's a more advanced stage of hypertension, then you're going to institute the non-pharmacologic at the same time as the pharmacological. And again, the non-pharmacological is the lifestyle changes, diet, and you have to know the diet that you're going to prescribe, exercise, the type of exercise you're going to prescribe, and the reduction of alcohol consumption. So the blood treatment threshold and the use of cardiovascular disease risk estimation to guide drug therapy. Some of you guys are not familiar with treatment in cardiovascular disease, but when we treat patients with, say, anti-lipids, we use a cardiovascular risk estimation to guide therapy. And we have introduced that into hypertension as well. So in treating patients with hypertension, you have to put them in a risk category. And that risk category will define a low risk group and a high risk group. So just, high risk group, you have to treat them more aggressively. So when you're treating patients with hypertension, you have to put them in a category that define the risk that that patient have. So remember, when we say this is the class of recommendations and this is the level of evidence, so the class of recommendation goes from class 1 through to class 3. Class 1 and class 2 is what you should do. Class 3 is usually contraindicated or can cause harm. And then the level of evidence, that means how much data there is, it can be A, B, and C. So the class 1 for doing your estimation. So the recommendation for blood pressure treatment threshold and the use of the risk estimator to guide drug therapy of hypertension. So you should use, so class 1, you should use your risk estimator. Use of blood pressure lowering medication is recommended for secondary prevention of recurrent cardiovascular disease events in patients with clinical cardiovascular disease and average blood pressure of 130 millimeters or higher, or an average of 180 or higher for primary prevention of adults and estimated risk. Okay, so let me explain what this is saying, because it's a little cumbersome. So what it is saying, that when you put your patient in the risk estimator, And I'm going to show you what the risk estimator is. It's basically looking at a series of things. It's looking at the patient age, the sex, systolic blood pressure, whether they smoke, yes or no, if they're diabetic. And it's going to put them in a risk. And it's going to be either a low risk or a high risk. So what this is saying is that if the patient is a high risk, okay, when you do your 10-year atherosclerotic cardiovascular disease risk, if the risk is 10% or higher, then they're in an high risk category, and you should treat the blood pressure to less than 130 over 80. That is class 1 indication with level of evidence A. So your high risk patient, that is, when you put all the information in the risk calculator and the 10-year risk is now above, greater than or equal to 10%, you have to get blood pressure lower. It has to be 130 over 80 or less, okay? Also class 1, but level of evidence C, if you use of blood pressure lowering medication is recommended for primary prevention of cardiovascular disease in patients with no history. So the first one is the patient, once a patient have a history of cardiovascular disease, then it is a secondary prevention, but you're still going to put them in the risk calculator, and it's going to be high risk. The fact that they already had a previous cardiovascular event, the majority of the time they're going to be in high risk, but you still put them in the risk calculator, and you have to get the blood pressure less than 130 over 80. So these are primary patients who have never had any cardiovascular events. And when you put them in the risk calculator, if the 10-year risk is less than 30%, that is low risk, you should treat them to get the blood pressure below 140 over 90. Okay, 140 systolic, diastolic should be less than 90. So try and get this concept because it's important. So high-risk individual and patients with secondary prevention, that means they already had a cardiovascular event, so a heart attack or something like that. And you put them in the risk calculator, and that risk calculator put them in high risk. You have to be a little bit more aggressive. So you have to get that blood pressure less than 130 over 80. If they've never had any cardiovascular events, and when you do your 10-year risk, if it's less than 10%, that is their low risk, you can be less aggressive. Treat it less than 140 over 90. Okay. All right. So when we treat blood pressure, just like how we use the risk calculator in other things, so the risk is based on approach to cardiovascular prevention. So you put patients in high risk because they have a higher risk to develop of developing cardiovascular problems, and then low risk, they have a low risk. So you're going to be more aggressive in your high risk patients. And what I'm telling you about is the ACC-AHA pooled cohort. That's what it's called, a pooled cohort equation to estimate the 10-year risk of atherosclerotic cardiovascular disease. So you should be familiar with the ACC-AHA pooled cohort equation to estimate 10-year risk. You don't have to memorize it, just be familiar with it a little bit. And remember, this is something that's going to give the patient risk. It's going to say whether they're high risk or low risk. So what we use it to do is to estimate the 10-year risk of atherosclerotic cardiovascular disease. And again, we're going to put them in high risk and low risk. The high risk patient, we're going to be a little bit more aggressive in those patients. So it looks something like this. I'm not sure if this came out looking too good, but so you have a category for the age of the patient, okay, and the age is from 40 to 75. Whether they're diabetic, yes or no, the sex of the patient, the race of the patient, whether they smoke, yes or no, total cholesterol, HDL cholesterol, and systolic blood pressure, and whether there's hypertension, yes or no, and if the hypertension is treated, okay, or not treated, and you put all these information in this data, and it will calculate the risk for you. You don't have to do the risk. So you can pull this, you can Google it when especially while seeing a patient, you can Google it, put the information in, and it will give you a risk. So it's going to give you a 10-year risk, and high risk individual, their 10-year risk will be greater than or equal to 10%, and then low risk is less than 10%. So when we talk about secondary prevention of coronary artery disease, that means the patient already had some cardiovascular disease event. They may have had coronary heart disease, they may have congestive heart failure, stroke. They have had some cardiovascular event, and what you're doing now is to prevent further cardiovascular disease by treating the blood pressure. So you have to be a little bit more aggressive. And again, remember, when we put them in the risk calculator, these patients are going to come out to be high risk. So you have to treat them to get the blood pressure below 130 over 80. Okay. And there's a number of study that, that tell us to do this. One is the SPRINT, systolic blood pressure intervention trial. It supports medication to lower the blood pressure above 130 without cardiovascular event. You lower the blood pressure, it results in benefit in higher risk individual. So essentially what we've been saying, the higher risk individual, treat them more aggressive, they will get more benefit from the treatment. So what we have found is that if their risk is less than 10%, so that means they're low risk, you can be a little bit less aggressive. You can treat systolic blood pressure above 140 or diastolic blood pressure above 90. It can be a little bit less aggressive, okay? But if they are high risk, then so high risk is if the 10-year risk is greater than 10%, then you're going to treat systolic blood pressure for above 130, diastolic blood pressure above 80. So even though I'm giving you a lot of data and information, essentially high risk individual, you want that blood pressure below 130 over 80, low risk, 140 over 90. All right, so how you follow up these patients. So the recommendation for follow-up is, so the class of recommendation, 1, level of evidence, B. So you should do this. It's a class 1 recommendation. So adults with elevated blood pressure or stage 1 hypertension who have an estimated risk of less than 10%, that means low risk, they should be managed with non-pharmacological therapy and have repeat blood pressure evaluation within 3 to 6 months. So this is your low risk patient. You give them non-pharmacological therapy, and you're going to bring them back in 3 to 6 months, and you're going to reassess them. Okay, so low risk individual, stage 1 hypertension. So class of recommendation 1, so you should do this as well. Level of evidence B. So adults with stage 1 hypertension, so stage 1 hypertension who have an estimated risk of 10% or higher. So this is a little bit high-risk individual, remember you have to put all your patients in this risk calculator. So stage 1 hypertension, but this is a high-risk patient. They should be managed initially with a combination of the non-pharmacological diet, exercise, reduction in alcohol consumption, and they should be started an antihypertensive drug therapy because they're high risk. You're going to treat them with blood pressure medication, and they should have a repeat blood pressure in 1 month. So the high risk individual, you're going to put them on medicine in addition to the non-pharmacological therapy, and you're going to see them back in 1 month. Again, the class of recommendation 1, class 1, adults with stage 2 hypertension now, so great categories. So remember your stage 1 hypertension, blood pressure greater than 130 over 80. Stage 2 greater than 140 over 90. So this is your stage 2 hypertension. They should be evaluated by or referred to a primary care provider within 1 month of the initial diagnosis. They should have a combination of both the non-pharmacological and the hypertensive drug therapy. And when we talk about drug therapy, at least 2 agents of different classes to do 2 different drug class medication that should be initiated, and they should have their repeat blood pressure in 1 month. So high risk stage 1, you're going to treat them in medicine. Your stage 2 patients, you're going to non-pharmacological plus medicine, at least 2 medicine, and you're going to repeat the blood pressure evaluation in 1 month. Okay, and then also class 1, adults with very high average blood pressure. So systolic greater than equal to 180, diastolic greater than equal to 110. So very hypertensive patient. They should be evaluated by prompt drug therapy. So you're going to give them, of course, you're going to tell them about the non-pharmacological therapy, but you're going to give them blood pressure medication. You're going to follow them up. You might do it in a month, or you might do it less frequent. All right. And then your class 2A. So this is a class of recommendation 2A. So you don't have to do it, but you probably should do it for good measures. For adults with normal blood pressure, to come to the office, normal blood pressure, you can repeat the blood pressure evaluation once a year. Okay. All right. So the stage of hypertension, presence or absence of target organ damage. So when we say target organ damage, that means the high blood pressure is now damaging organs. The patient may have had a stroke. They may have ophthalmic features of elevated blood pressure. LVH, when you look at the heart, the muscles are thickened, LVH. They may have some chronic kidney disease. So there is evidence that the blood pressure is causing problem. That's what we call target organ damage. So if you have elevated blood pressure and stage 1 hypertension, when you do your risk calculate, is less than 10%. So this is what we just showed you a while ago. So your stage 1 individual, risk less than 10%, you do your pharmacological therapy, and you can bring them back in 3 to 6 months and check the pressure and see how well all things are working. Okay. But your stage 1 now, so these are patients with blood pressure greater than 140 over 90, and usually their risk, when you do the risk calculator, is greater than 10%. You do your non-pharmacological, but you're going to use medicines. And these are the patients that you're going to repeat the blood pressure check and see if they're compliant to their medication in 1 month, not 3 months. Stage 2, blood pressure greater than 140 over 90. You're going to evaluate them very promptly, and you're going to treat them with medicines. You're also going to stress non-pharmacological, because diet is an integral part of the treatment of hypertension. Diet, exercise, and cessation of alcohol consumption. And So you're going to give them medicine and you're trying to reduce the risk of target organ damage. You want to prevent the stroke. You want to prevent the LVH. You want to prevent the chronic kidney disease. So if someone have what we call normal blood pressure, and we alluded to this before, if someone have a normal blood pressure, the lifetime risk of developing hypertension is greater than 80%. So almost everybody is going to get hypertension. So you should know what to do. So the changes in blood pressure is related to sedentary lifestyle. That's why we always recommend exercise. Dietary sodium intake, people eat too much sodium. Body weight, people have too much weight on, and alcohol consumption. Okay, so you should screen these patients. So even someone presents with a normal blood pressure, it's reasonable to screen them on a yearly basis. It has a 2A recommendation though, class 2A. So the general principles of drug therapy. So medication is an integral part of the treatment of hypertension. So when we use medication to treat hypertension, we should give agents that reduce clinical events. Okay, those should be used. We have medications that can reduce blood pressure, but in the studies that we have done, there's some medicine that will reduce clinical events more than others. And we have a primary list or a primary group of medicines that should be tried first. So someone come say a stage 1 hypertensive, they're low risk, and you do your dietary manipulation, lifestyle changes, you bring them back 3 to 6 months, the blood pressure is still elevated. These are the primary agents. These are the medicines that you should use. Thiazide diuretic, ACE inhibitors, ARB, or calcium channel blockers. These are the primary agents. So it is recommended that you use these 4 medicines, these 4 group of medicines first before you go on to others. So again, your stage 1 hypertensive individual, blood pressure greater than 130/80, you may only have to use 1 agent along with your lifestyle changes. Stage 2 hypertension, your lifestyle changes and stuff, but you may have to use 2 drugs of different class. So you might want to use an ACE inhibitor and a diuretic, a thiazide diuretic. Okay. Other general principle of drug therapy, you have to take into consideration the patient age. Older patients tend to be more sensitive to medication. They may have more orthostatic hypertension, okay, concurrent medication, what other medicines they're taking to make sure there's no conflict with the medicines. You have to look in terms of drug adherence and costs, drug interaction, and comorbidities. So these are some guidelines to the general principles of drug therapy. So class 3, which means it's not indicated or it can cause harm, is put in red. So you should not simultaneously use an ACE inhibitor or HARB or a renin inhibitor. It can be harmful to the patient and it is not recommended. So do not use an ACE and a HARB or a renin inhibitor. Okay, it's not only contraindicated, it can cause harm to the patient. Okay, so class 1 recommendation, level of evidence, BC, for adults with confirmed hypertension and known cardiovascular disease or 10-year atherosclerotic cardiovascular disease in a risk of 10% or higher, is your high-risk individual. The target blood pressure should be less than 130/80. So your high-risk patient, so you're going to put them in the risk calculator, it's going to come out to be above 10%. You should try and get that blood pressure below, 130/80. Okay? For adults with confirmed hypertension without additional markers of increased cardiovascular disease risk, a target blood pressure of 130 is reasonable. So essentially, you should try, especially if the patient is high risk, try and get that blood pressure below 130 over 80. 130 over 80. So, I mean, it's probably only three numbers you need to remember in this current guideline: 140 over 90, 130 over 80, and 120 over 80. You need to know the normal blood pressure. You need to know for high risk individual, you're going to get that blood pressure below 130 over 80. And if they're low risk, 140 over 80, less than 140 over 90 is reasonable. All right. So these are the medications. Remember, we talk about the primary agents and thiazide diuretics. Okay, so you can have your HCTZ, that's a thiazide diuretic. So you have chlorthalidone. This is your HCTZ, hydrochlorothiazide, indapamide, metolazone. So these are, and you can look them up at your leisure. And these are the dose recommendation of frequency you should give these medicines. And then some comments. So the chlorthalidone is preferred on the basis of prolonged half-life and proven trial reduction. What is so funny is that most patients who come to see you and they have had some treatment for hypertension, they're on hydrochlorothiazide. But when you look at the studies, almost all the studies use chlorthalidone. I just don't understand that, I mean, I use primarily chlorthalidone, but it's longer acting. Well, anyway, these are the thiazide diuretic drugs, your primary agents. Then ACE inhibitors, there's a bunch of them. Your benazepril, captopril, enalapril, lisinopril. Some of these we use more often than others, but with ACE inhibitors, you again remember, do not use the ACE inhibitor with HARBs or direct renin inhibitor. That's a class 3. And you can increase the risk of developing hyperkalemia, especially in patients with chronic kidney disease. So be careful about that. If the patients have renal failure, there's an increased risk of renal failure in patients with severe bilateral renal artery stenosis. So remember that if they have bilateral renal artery stenosis and you give them ACE inhibitors, they can develop renal failure. And you can get angioedema with ACE inhibitors. Do not give ACE inhibitors in pregnancy. Avoid it. All right. So what about the HARPs? So these are your angiotensin receptor blockers. The ones that we use a lot of is the losartan. We use valsartan. Some people use telmisartan. Okay. So these are candesartan. So you do not use in combination with ACE. You remember we're stressing that. It's a class 3 or direct renin inhibitor. You can get increased hyperkalemia in patients with chronic kidney disease, or if you're given potassium supplements, so be careful. Increased risk of renal failure in patients with severe bilateral renal artery stenosis. So you're going to get a lot of the same things that you get with your ACE inhibitors. Do not use if the patient has a history of angioedema with a HARB. So a patient with a history of angioedema with ACE inhibitor can receive ARB 6 weeks after the ACE was discontinued. And again, do not use HARBs in patients who are pregnant. Calcium channel blockers, that's also a primary agent. We use amlodipine, nifedipine, but this is the complete list. Sometimes we use felodipine. This completed list. You do not give. This is the dihydropyridine calcium channel blockers. Okay, the dihydropyridine calcium channel blockers. Avoid in patients with heart failure with reduced ejection fraction. Except you can use amlodipine, Phencylamine, you can get some leg edema, so remember that. And then this is your non-dihydropyridine calcium channel blockers, which includes your diltiazem, verapamil, and stuff. Again, do not give to patients with heart failure with reduced ejection fraction. You know, a lot of patients come to see me and they're on diltiazem and they have heart failure. Their ejection fraction is 20%. And I stop it and send it back to the primary care. The primary care get upset. You know, they just don't, they're using medicines and they don't know how to use the medicine. So do not use the non-dihydropyridines in patients with heart failure with reduced ejection fraction. So remember that. So these are secondary agents now. So we look at the primary agents. The primary agents is your thiazide diuretics, your ACE inhibitors, your HARBs, and your calcium channel blockers. Secondary agents includes loop diuretics, bumetanide, furosemide, torsemide. So these, you know, we'll use these in patients who have moderate to severe kidney disease. Your thiazide diuretics is not going to work, so you have to switch over to these loop diuretics. Potassium sparing diuretics. So most diuretics we use will deplete, cause potassium depletion. These will prevent potassium depletion, amiloride and triamterene. But these are secondary agents. You would not start a patient on these agents. Aldosterone antagonists. These are also secondary agents, and the ones that we use is eplerenone, spironolactone. Remember, patients with renal failure, they can develop profound hyperkalemia with these drugs, so you have to follow the renal function very closely. Beta blockers, okay? So these are the beta blockers. So we're talking about atenolol, bisoprolol, metoprolol, tartrate, and succinate. So beta blockers are not primary agents. Let's stress it. Beta blockers are not primary agents. So beta blockers are not recommended as first-line agents unless the patient have ischemic heart disease or heart failure. So there have to be specific indication to recommend the beta blockers, ischemic heart disease or heart failure. So patients who have bronchospastic disease, you want to use a beta-1 agent as opposed to a non-selective agent. If the patient have heart failure with reduced ejection fraction, bisoprolol, metoprolol, those are the ones that are recommended. So these are beta blockers with cardioselective and vasodilatory we don't use a lot of that. So again, we used to use propranolol. We don't use propranolol that much. But beta blockers with intrinsic sympathomimetic activities, which includes your Pindolol. We don't use a lot of these anymore. So beta blockers with combined alpha and beta receptor blocking. Carvedilol, we use a lot of carvedilol. Okay, so carvedilol is also preferred in patients with heart failure with reduced ejection fraction. Avoid abrupt cessation of, and then the direct renin inhibitors, the aliskiren. So you're not going to use that with ACE or HARB, and you're going to avoid it in pregnancy. So again, secondary agents, your alpha-1 blockers, your doxazosin, prazosin, you can, if the blood pressure is not controlled and you're following them up, these are agents that you can try. Your central alpha agonists and other centrally acting agent, clonidine is one, methyl-dopa, so then your direct vasodilator, hydralazine, minoxidil. So these are secondary agents. You should try the primary agent first. If they don't work, then you move on. Another important point is thiazide may stimulate the renin-angiotensin aldosterone system. So it's reasonable to combine a thiazide diuretic with an ACE inhibitor. Since the thiazide is going to stimulate the renin-angiotensin-aldosterone system, you can use an ACE and a ARB. And that's what we say complementary action. So drug combination that have similar mechanism or action should be avoided. So you don't want to use drugs that have similar mechanism of action, such as two different ACE inhibitors or your dihydropyridine calcium channel blockers or your ACE ARB combination. Don't want to do that. So again, when you treat blood pressure to goal, intensive blood pressure control improves major cardiovascular disease outcome, and that is why we are aggressive. You know, patient will come to you and say, "But doc, I don't feel anyway. I'm doing fine." You know, you have to stress to them that you're trying to reduce or improve cardiovascular disease outcome, and we cited a number of studies. You know, we look at the SPRINT, the ACCORD, and those studies help us to treat blood pressure. One of the most recent meta-analysis where we combine a number of studies from 42 trials with 144,220 patients, there's a linear association between the mean systolic blood pressure and the risk of cardiovascular disease mortality. The lowest risk was systolic blood pressure between 120 and 124. And patients with the highest risk usually benefit if you lower the systolic blood pressure below 120. So essentially, you know, try and be aggressive. So all this is a very busy slide, but this is what I've been telling you before. So blood pressure thresholds and recommendations for treatment and follow-up. So a normal blood pressure less than 120 over 80. So you know, you're going to stress lifestyle modification to everybody, whether they have high blood pressure, yes or no. And then you can reassess those patients in a year, you know, even though they may develop some habits or they may develop hypertension during the year. So you can see them back in a year. If remember, one of the category in the current guideline is the elevated blood pressure. These are individual with blood pressure systolic 120 to 129, and the diastolic usually 80 or less. So your lifestyle modification, okay, non-pharmacological therapy, you can reassess those patients in 3 to 6 months. Your patient with stage 1 hypertension, that is systolic blood pressure 130 to 139, diastolic between 80 and 89, okay, and then you're going to do your risk you put them in that risk equation, you Google it, you put all the information that is required, and if their 10-year risk is greater than 10%, that means they're high risk. So if it's yes, they're high risk, so you're going to treat them with medicine. So non-pharmacological approach and medicine. You're going to reassess them in 1 month, and if they're at goal, then great. You know, you can see them in 3 to 6 months. If they're not at goal, you're gonna assess and optimize adherence. Are they taking the medicines? You know, are they taking over-the-counter stuff? Okay, do all those sort of stuff. So if you put them in the risk calculator and they're not high risk, then you do non-pharmacological therapy. Reassess them in 3 to 6 months. These are the big guns. A patient with stage 2 hypertension, blood pressure greater than 140 over 90, you're going to put them on non-pharmacological and pharmacological medicine. You're going to reevaluate them in a month. So this is basically what we went over in detail. So let's stop here, and we can pick up on Thursday.